Okay. But just to give you a little bit of a kind of positive on this, you know, there are some beautiful research projects out there that are looking at ways of managing insomnia in children with neurodevelopmental differences. Most of the work so far has been in children with autism spectrum disorder and children with ADHD. And there have been much smaller projects in children with Down syndrome, but there are some projects out there that have looked at approaches, what we call psychoeducation approaches. So working with parents to promote good sleep habits and teach people different tricks of the trade, if you like, to try and manage some of these really tricky situations at bedtime. And they do work. They do work. And there's been different ways of doing it. You know, some people do it with a therapist, some people do it with an online website or a digital intervention. And there's been enough work in children with autism that somebody's been able to lump all the research together in something called a meta-analysis. That's just a fancy scientific way of putting all the data together and seeing if there's a truth in amongst the data. And those sort of analyses show that these interventions genuinely do work in children with autism. And certainly from my clinical experience, there are a lot of gains that can be made from these approaches as well in children with Down syndrome. So I just wanted to skip through some facts really about what we call sleep hygiene, or what we like to call more commonly now good sleep habits. So what are the simple things that we can do that help all of us sleep? Bedtime routines. It sounds kind of boring, doesn't it? It sounds pretty obvious, but it is the bedrock. It is so, so, so important. Children really benefit from that stepwise sequence of events leading up to bedtime. And the more rigid and the more same it is, the better for the child. And I've got some pictures there of, you know, visual timetables. These things are great for children. Countdown timers so that they know they've got, you know, 10 minutes before bed or whatever. And it's based on sort of classic psychological theory. You learn to associate a sequence of activities with what's going to happen next. And I think, you know, we have to remember none of us make a sudden transition very easily, do we? We like a little bit of preparation. We like to know what's coming next. We like to prepare ourselves for change. And children are very much the same. And, you know, if you could make that a positive time as well, and I think most people do intuitively make bedtime a positive time, whether it's a bit of one-to-one time, a bit of quiet time, a bit of story time, you know, whatever the child enjoys. So especially it might be massage, you know, there's all kinds of things that children like. Everybody knows their own child best of all. And building those into the bedtime routine can be very helpful. And we tend to say, you know, start that journey to bed about an hour before, and using signals and cues that your child understands. And keeping it calm is very important, nothing too exciting. Things that children do in the day help sleep as well. And we know now that exercise is helpful, and the more the better, to be honest. So this was a study of school-aged children, a big study of almost 600 children. Every hour a child sat down in the day meant they took 3 minutes longer to fall asleep at night. So the more active you can get your children, the more likely they are to fall asleep. And this is what the UK CMOs are recommending now. It's quite interesting. More than 3 hours for preschoolers a day, more than an hour a day for 5 to 11-year-olds. So I think thinking about where we can get that in, it might just be walking home from school rather than taking the car, you know, just building it in. Active time outside and in daylight actually as well is really helpful for children wherever you can get it. Thinking about children's diet, people don't always realize where caffeine sneaks into food, and caffeine is the best way to keep your child asleep. And it can last in your blood and in your system for about 6 hours. So think about your child's bedtime. We really strongly recommend avoiding things like chocolate or fizzy drinks that have caffeine in. Tea and coffee, people know have caffeine in, but look how much you need. So an average 5-year-old, 25 milligrams is enough to stop them going to sleep. A 28-gram bar of dairy milk, and they've had 15 milligrams. Yeah. So a can of Coca-Cola, they've had twice as much as that. So it sneaks in and you don't always realize. And there's a big myth, isn't there, around hot chocolate's great for children at bedtime. So we tend to say, if you can, if your child's struggling to settle to sleep, really be rigorous and try and avoid caffeine wherever you can. The bedroom environment, so keeping it about the right temperature, not too hot, not too cold. 18 degrees is perfect. Keeping it quiet. And the thing with noise is it's sudden unexpected noises or changes in the background noise that tend to wake us up at night. So a continual noise, often we just acclimatise to. So children get used to a road noise or a rail track near the house, things that they're familiar with, you know, the drone of aeroplanes overhead. We don't tend to wake up once we're used to those things, but sudden noises like a telephone ringing or a voice, this sort of thing will wake children up. Dark is so important. Okay, so the journey to bedtime, get those lights dimmed. If you've got a child that's afraid of the dark, that's very common. Try to use a night light and try to have an orange or red night light, not a white one. Okay, because white light or blue light stop our body making the sleepy hormone melatonin. And screens, of course, you know, all those lovely tablets that we've got now, phones, TV screens, they spit out blue light and they stop our bodies making melatonin. Melatonin just helps ease us into sleep, and it's incredibly important. So dim light and red light or plug-in orange lights if your child wants a bit of light to reassure them at night. I think we all kind of intuitively know that a bed is helpful, and being comfortable and being horizontal is helpful. Although, you know, in some cultures, people sleep semi-seated. There's all kinds of different ways of doing it, but most of us like to sleep horizontally. Not too stimulating. I think often I think we make the mistake as parents to think, you know, my child's not sleeping, I've got to make the bedroom nicer. If the bedroom's nice, you know, if I paint the walls this way, or if there's, you know, nice toys in there, if it's a lovely place, then my child will sleep. And of course, it's a kind of confusing message sometimes for a child. So actually a boring bedroom is the best kind of bedroom really to sleep in. And safety, of course, is really, really important. If you've got a child that might climb out the window, you want window locks. If you've got a child that might run around with a night terror or a sleepwalking, you want to make sure the house is nice and safe. And we tend to say, you know, if your child struggles to understand bedtime, if your child has learning disabilities that makes that difficult to understand, I think having a bedroom that's also a play center in the day is really confusing. That, you know, you're going to this space again, but now you've got to do something different. So we tend to say to parents, you know, if your home doesn't have the capacity to separate out that space, put the toys in a little box and wheel it out. You know, so all those tempting things aren't there anymore. Just comfort toys that children might need to sleep is all that's needed. And just to make you think, there's a wonderful book, Where Children Sleep Around the World, and just look at some of these images. So that's an example of a bedroom that's not great for sleep. You know, stuffed full of toys and entertainment. So, you know, would you go to sleep in there? I think you'd be, you know, be kind of challenging, wouldn't it really? And this one, if you kind of have a quick squint around, look at all the electronics. A lot of electronics in the bedroom. You know, we know that electronics have huge benefits for children in terms of learning, and lots of children are really soothed by electronics. But as I say, we do have this real problem of blue light and accessibility. You know, if it's there at 3 in the morning when you wake up, it's too tempting, isn't it, to want to hop on and have a look. And it's very tempting as parents to think, well, okay, it soothes the child, everybody gets a night's sleep, let's leave it be. So I think we have a real challenge in this day and age, don't we, around accessible tablets and electronics. And I'm just putting that up there because, you know, there's an increasing vogue, isn't there, for sleep pods. And actually, as intelligent adults, people pay money to pop into these. This is actually all you need, isn't it? In real life, that's all you need to sleep. A dark, safe, comfortable space. So have a little bit of a think about what we're doing sometimes to our children's bedrooms. And, you know, for many children, safety sleepers, and there's a whole bunch and variety of them out there, can be a really helpful way of keeping a child safe at bedtime, and actually giving a beautiful, clear message. This is your lovely, safe sleep space. This is where you go to sleep. It's not a play space. So for some children, that kind of a sleep space can be very helpful. Screens I've talked about, I won't labour this, but there's loads of data now showing that more time on screens, even in toddlers and preschoolers, it knocks their nighttime sleep and they take longer to fall asleep. And in school-aged children, they're more likely to be sleepy in the day and to not have enough sleep at night. It's not a kind of myth. It's not kind of, you know, PC goody two-shoes people saying keep your children off screens, it really does make a difference. So we've really got to find that delicate balance, haven't we, between all the wonderful, wonderful benefits of screens and keeping the time reasonable. And it might be because sometimes children are using the screens instead of going to sleep. It might be that they're too stimulating at bedtime, but we know that light has a big effect. I think we do have to pay a little bit of attention to things like pain, medical problems like gastroesophageal reflux. You know, if a child's refluxing up their tummy contents and they've got a sore gullet, that's going to make it hard when you lie down flat. Is your child hungry? Has your child sort of had their sensory needs met? These are all important questions to ask. So here we go. It's a bit of a jigsaw puzzle, isn't it, sleep? So to do it well, we've got to be in the right environment, or it helps at the very least. But that's the bedroom environment, but also the child's internal environment. You know, are they calm? Are they comfortable? Are they free of pain? Are they satiated but not too full of food? You need to be tired, that's self-evident, and your body clock needs to be on the right time zone. And once all those things are all beautifully lined up, you've actually got to make a positive choice to go to bed, because you can make a positive choice not to. We can all decide not to go to bed on any one particular night, even if we're absolutely dead dog tired. Okay, so I haven't got a clock that I can see on my screen, so I'm a little bit conscious of time, and we've got some lovely presentations to come as well. So I'm going to be really speedy, I think, and just tell you a little bit about sleep apnea. I know Liz is going to focus a bit more on this, but for those of you who are not familiar with this, just a little bit of an explanation. At the moment, whilst we're awake, all of you are keeping your upper airway open. So upper airway, I mean from your lips to your Adam's apple. The reason it's open and allowing air to flow beautifully and freely is because your muscles are working. Those muscles are nice and functional. Okay, so air moves through, and you can see somebody lying on their back there. Air's moving through beautifully. When you fall asleep, those muscles relax. Now, for most of us, it's a nice big space. It doesn't matter, the muscles relax. The air's still flowing through beautifully. However, if there's anything about your makeup, about the way your face is structured, if you've got a big tongue, if you've got big adenoids or tonsils, which lots of little children do have, or if you're just a little bit extra floppy, or if you're a little bit overweight and your throat's a bit squeezed because of fat layers in your neck, all of these things can make that flop down a little bit more. And if it flops down a little bit more, you snore. So snoring is just because that airway is a little bit too floppy and a bit too shut. Snoring in of itself is probably okay for most of the time, but then occasionally it just flops down completely, and that's called sleep apnea. So it's completely flop shut, and you can see that that space has gone, that nice space there where the air goes through has gone. And our bodies and brains are quite clever, because obviously having that shut for too long is not a great idea, because you're not getting air in, you're not getting oxygen in. So what tends to happen is your brain says, hang on a minute, you need to wake up. Your muscles come back into action, and the airway opens again. And that's called obstructive sleep apnea. And children with Down syndrome have certain increased risk factors compared to non-Down syndrome children. So part of it is around facial shape that can make them a little bit more vulnerable. If you're a little bit more floppy anyway, that makes you more vulnerable. If you put weight on, and this is true for all children, it makes you more vulnerable. And of course, children are children, and adenoids and tonsils, which sit here, can you see is a nice open airway. See that black line? This is just a scan looking cross-sectionally through the head. So you see a lovely open airway down there. Here's a nice big chunky adenoid at the back of your nasal passage. That's the palate there, and that's the tongue. And here's a nice big tonsil. And can you see they're just blocking that airway right up? So, and here's a little chappy with nice big juicy red tonsils. And children grow their tonsils from the age of 2, and they shrink down usually by the time they're about 8, and they just fill that space up, and often that is the cause of sleep apnea in many children. Okay, so what do we look out for? Snoring, that's the cardinal sign. And what happens when you have an apnea is you're snoring away, and then as a parent you'll hear it stop. The snoring stops, there's a little bit of a pause, the brain's waking up, the muscles are kicking in, and you suddenly get a sort of big gasping noise. So parents will say they're hearing this gasping noise at night. Sleep it tends to be more restless. It might be associated with bedwetting or difficulties becoming dry at night. Children are often quite sweaty. They may sleep with a head right back in funny positions to try and keep that airway open. Some children will sleep kind of flop forwards with their sort of legs open, so you're kind of putting your head down, so that takes the tongue away from the back of the throat. And in the morning, they might have a headache or a dry mouth, so they might do a lot of drinking at night. Often they're mouth breathing during the night, so you'll get a sort of Darth Vader-y sort of breathing noise, a noisy breathing, if you like, during the night. So a bit of a problem with this, these symptoms are all present at night. And do you remember that first graph where I showed you the red lines of the dream sleep where children are more vulnerable to this? That really happens more as the night goes on. So often 3, 4, 5 in the morning when everybody else hopefully is asleep. So parents often aren't aware of this, of what's actually going on. And the problem is the impact on the daytime is really non-specific. It might affect children's learning, development, ability to pay attention, all that stuff I talked about earlier that can happen in the day. But none of that says to you, my child's got sleep apnea. It just says, my child's having a bit of a struggle managing their behavior or whatever. You might not know that the child's got sleep apnea. And you take your child to the doctor and they look fine. There's nothing to see because they're awake. And we know that if you examine a child, you can look at their tonsils, but actually the size of the tonsils is not a great predictor of sleep apnea. So I think, the golden message here, the main message is the only way we know is a sleep study. No doctor can tell you your child doesn't have sleep apnea unless they do a sleep study. You have to have a sleep study to know. So that, I think, is the main message, and that's the message we've been trying to get out. And the research that we've been doing is really sort of thinking about how can you do that best in the UK? How can we do that within the NHS? And how often should we be doing it? In America, they say do it once up to your 5th birthday, and then you're probably fine. Just ask the questions every year. And at the moment, we're trying to promote a sort of annual simple screening for children because children can develop it later. You can have it at any age and stage, particularly if a child puts weight on. Okay, so if you've got it, what do you do about it? So this is what the European guidelines suggest for all children. The first most important thing is if a child's overweight, then weight loss can really help because pressure from fat in the neck pushes on the airway. So if you can reduce weight, that's helpful in lots of ways, but certainly can be very helpful for apnea. Sometimes if the nose is very inflamed, then nasal sprays can help if your child's got a really blocked, snuffly nose. I guess the mainstay of treatment is removing those tonsils and adenoids and trying to open that space up a little bit. There are some fancy things that can be done as well. There are some surgical approaches that can kind of change either the tongue or the sort of facial structure. And there are some appliances that can be used to sort of keep the jaw forward at night and keep the mouth open. And then a more common approach, if children either can't have adenotonsillectomy or have had it and it hasn't worked, is to use CPAP therapy. And I'm not going to talk about that now because I know Lizzie is going to talk about that afterwards. But that's where children wear a mask to bed. There was a lovely picture of David with his mask, wasn't there, at the beginning, that actually blasts a little bit of air into the nose and mouth and just splints the airway open. So it's a really simple idea. All you're doing is putting a little bit of pressure in that airway to sort of hold it against the muscles that are trying to flop down. So that's called CPAP, or continuous positive airway pressure. And one of the things that we have been doing over the past year, very generously supported by the Down Syndrome Research Foundation, is doing a big review of the literature. So we've looked at all the research studies out there, spent a lot of time looking at what's a good quality one, what's a bad quality one, merging all the data and saying, do you know how well does adenotonsillectomy really work in children with Down syndrome? How well does CPAP really work? And so we've got some very exciting data there that we're just finessing to send off for review for a journal to be hopefully published in the not too distant future. And I can tell you the headline from it is, we need more data and we don't really know. There hasn't been a single gold standard decent trial, which is quite shocking when you think that, we are currently Europe-wide and worldwide recommending adenotonsillectomy in children. It definitely helps quite a few children, but it doesn't help all children. And we need to be much, much smarter about how we treat this. And we desperately need a proper randomized, what we call a randomized control trial, where children are allocated by chance to get one treatment or another, so we can work out which is the right treatment for which children. So I think that's a very exciting next step. So just in summary, sleep problems overall affect about 85% of children with Down syndrome. So if your child has had a sleep problem or is having a sleep problem, you are certainly not alone. Just remember, a sleep problem is a symptom, and it could be a lot of different sleep disorders. Obstructive sleep apnea is super common. So we're estimating approximately 65% of children overall will have some degree of sleep apnea, but it's not the whole explanation. And I strongly sort of feel, you know, children with Down syndrome are children first, and things that affect other children will affect children with Down syndrome too. And behavioural insomnias that I talked about are very common in my experience and can be prevented, I think, with early intervention, and can certainly be helped. And I think quite often that does need support and expert help. It can be quite a difficult, challenging one to do alone. So thank you for listening. Thank you for your time.